Alan Seftel, Chief of the Division of Urology, Cooper University Hospital, and Professor of Urology. I've been asked to be an advocate for the position that the urologist should screen the patient with erectile dysfunction for cardiovascular disease risk factors. The first piece of information is data that has come from Ian Thompson's group looking at the patients in the prostate cancer prevention trial. So the men with erectile dysfunction over the course of the study are also noted to have a 11% chance of having a cardiovascular event. Thus, the data suggested that erectile dysfunction preceded the cardiovascular event and could be a predictor of cardiovascular disease. The second important piece of background information, data that we published also approximately 10 years ago in the Journal of Urology, we found that 272,000 patients with a diagnosis of erectile dysfunction had a variety of associated cardiovascular diseases. These diseases included hypertension, diabetes, hyperlipidemia, and depression. The prevalence rates of these diseases in these men with erectile dysfunction were about 42% for hypertension, 42% for hyperlipidemia, about 20% for diabetes, and about 12% for depression. Thus, the two data points suggest that not only is ED a predictor of cardiovascular disease, but also that ED is associated with cardiovascular risk factors. So those data points suggest that indeed the urologist needs to be cognizant of the fact that erectile dysfunction, when seen in the office, should signal the need for cardiovascular disease risk screening. The reality is most people are doing this already in the office, and this should not be enigmatic. When a patient comes in and you're doing your standard history and physical, that you're accomplishing a great deal of cardiovascular risk screening right then and there. After you ascertain the diagnosis of erectile dysfunction, you ask about exercise capacity, hypertension, diabetes, family history of cardiovascular disease. You go through a smoking history, a drinking history, and you go over their medications. The reality is you've ascertained a great amount of information just based on that discussion. You then go through your physical exam, you do your height, your weight, your blood pressure, waist circumference, you evaluate the pulses. Now, in my practice, I offer the patients a variety of laboratory tests. I do a urinalysis in the office via dipstick. We do fasting lipids, fasting glucose, and a serum testosterone. Now, these tests are screening tools also for cardiovascular disease risk factors. So, for example, if a patient has a glucose of over 150, then usually the dip is positive in the office for glucose, and you'll be able to then tell the patient they should see their primary care physician for the evaluation and treatment of diabetes. So just based on those two tiers, the history and physical and the laboratory testing, the urologist has really accomplished 2/3 of a cardiovascular disease risk assessment. So the real question that's on the table is, what is the next step? The current state of knowledge comes from the algorithm provided by the Princeton 3 Consensus Conference, published in August 2012, showing that essentially at this point, once you have the patient in the office, once you've done the history and physical and the laboratory testing, you now need to risk stratify the patient. The patients in the gray zone are the ones that really require some thought and some care about what the next step is in their processing. Do you send them for an exercise stress test? And that would allow you to re-stratify them into either a high-risk or low-risk group. Or do you send them back to their primary care physician or to their cardiologist and ask them, the cardiologist, the primary care physician, to perform these tests? In either event, the patient will get risk re-stratified into either a high-risk or low-risk group. My argument is simply that urologists should be able to order the exercise stress test. It's rather simple and straightforward. Insurance companies cover this. I've never had it denied. And this way, you will really subcategorize or risk stratify your patients based on the results of those data. I think that this allows the urologist to become an advocate for the patient. It helps the patient understand what their exercise capacity is and their risk is for cardiovascular disease events before they re-engage in sexual activity. This is independent of medication. This is really a risk stratification for all elements of sexual activity resumption. So again, I would argue that the urologist should at least be facile with understanding if the patient is high risk, low risk, or indeterminate risk. And then if you're not comfortable ordering the exercise stress test, at least be aware of the fact that the patient needs to be risk re-stratified, and then have the patient seen by the cardiologist or primary care physician. I think, again, the message is that the urologist is already doing cardiovascular risk screening, and this should not be a daunting task. You're already doing it in the office, and you haven't really realized it. So you can be congratulated for doing so, because you're an advocate for the patient by just doing your history and physical and laboratory testing. Thank you very much.